So let us begin today's integrated MCQ round. Are you all ready to, fire the chat box and let us know that you are, following us? And I'll request Dr. Tushar to maybe start the proceedings with the clinical scenario or the case, however you have planned, and then maybe I can show you the radiological findings of that case. We will try to, solve at least a lot of MCQs from this particular topic today. That is our, promise today. So by the time I think Dr. Tushar works out the slide share part, let me just tell all the students that there is a lot of noise around the word next, and I thought by the time we get the things going, I just wanted to address it to you that we are now very clear that we are looking at the next exam in January 2023 until and unless the government changes something. There are protests by the medical associations regarding this dateline that the health minister has declared. So let's see how it goes on. But as of now, the date of next is January 2023. And if you are a final year or a third year student, you know that you're looking at the probable next exam in future. So I'm sure you would appreciate that, our initiative of integrated curriculum, our initiative of integrated MCQ rounds actually preceded the government announcement. So, you can see that, we are totally committed to the cause, and we are able to, say, we're trying our best to make sure that, our students should have the advantage in this new pattern. The new pattern is going to be a lot more integrated. In the new pattern of the paper, you will have a lot of system-wise questions. And that is the approach we will try to do today. We will look at orthopedic disease and we will look at the radiological findings together so that, we get an idea on, I want you to understand these few buzzwords for the exam pattern. One is called as the, system-wise study, not subject-wise. So we are going to look at a system. Second is a disease complex or a symptom complex based approach. So that means, like, suppose I'm giving you a hint that what we are going to talk about today. Suppose you have a patient with tuberculosis or bone tuberculosis. Now this patient would have some clinical findings, some radiological findings, and everything put together around that symptom complex. So it is important to know that these are the buzzwords of the new pattern in the exam: system-wise learning, case complex based study, and clinical vignettes. So we are now looking at a changing exam pattern, and we are making sure that you have the edge on this. So already we have done, I think, lots and lots of integrated MCQ rounds on this series. You can see them on the eMedicoz app. Every Tuesday we do a integrated round. Every Wednesday we do a clinical grand round, considering the changed pattern and considering the new pattern in the exam. So let me see if Dr. Tushar is able to join or not. Dr. Tushar, are you able to join now?
Sir, I'm trying to share the screen, but I don't know. I have the sharing rights also, but मुझे समझ नहीं आ रहा. I don't know what is going wrong.
Is it an iPad?
No, it's Surface.
It should show. Just try on the share screen and select full screen.
I'll just log out and maybe I can log in again.
Okay, you can do that, but till the time. Okay.
Just 1 minute, guys.
So, so the case that we are going to discuss today, I'm going to give you a hint on it. I have already given you a hint. Is going to be skeletal tuberculosis, and we are going to look at one of the common sites of skeletal tuberculosis together. And I'll show you how and why of the radiological imaging. Dr. Tushar will talk about the clinical methods and the treatment of the disease. But in addition to this, I also want you to know that there are things which are happening very, very fast in the next 1.5 years. Next 1.5 years is going to be a very crowded year as far as the landscape of medical education is concerned. So what I would want you to do is that, if you are right now, you are thinking that I will read in my internship, I will not study today. It's a time to wake up and make your plans accordingly. We are going to have NEETPG in September 2021. Then in 2022, we will have another NEETPG. Probable month where they will conduct the NEETPG next year should be April, because if they do it before that, the current batch students will have a disadvantage that the people who are appearing for NEETPG, they will not even have their counselings over. You can't do a paper again till the time previous counselings are over. So April 2022, you will have the next NEETPG exam. After that, in January 2023, you will have next exam. That means thereafter NEETPG will be replaced by the next exam. and it will also replace the FMG screening exam, and it will act as a licentiate exam. That means once the next exam is introduced, and if you're finishing your final year at that time, if you pass the next part 1, which is going to be an MCQ based integrated system wise approach, if you pass it, then only you are eligible for internship. So it is very, very important, things happening around. You might have seen that even in our question bank, we have introduced a separate section called as system wise Q bank. We have introduced a lot of clinical vignettes in our Q bank. We have introduced a lot of clinical vignettes in our test and discussion program, and even in your class tests. So I believe that the landscape is going to change very, very fast. So people who have started early and who are right now starting early have a big advantage, because whenever the landscape changes, so people who will be unaware of the change in landscape will find the paper a little tricky. The entire idea of NMC now is that they want to make sure that in 2023 they do next part 1, and in 2024 they do the next part 2. So I think Dr. Tushar has been able to share the screen. Dr. Tushar, are you able to put on your camera?
Okay. Perfect. So very, very good evening to all of you. I'm Dr. Tushar Mehta, orthopedic surgeon and faculty of orthopedics at AIIMS. So today we have an integrated session. I really apologize for this delay. There was some, I don't know what kind of error was that. So let's start. Simple topic, very simple question. We see these kind of cases on and off, and I'm sure you will be able to understand. India ho और tuberculosis की बात ना हो तो I've already given you a hint. So a 20-year-old male presents with backache for last 2 months. Guys, you have to understand it is 2 months. 2 months is very important. There's history of loss of weight and loss of appetite. Honestly, when we ask to our patients in our OPD, we normally don't ask them about loss of weight and appetite. We ask them whether the old clothes which you were fitting in properly, now what about that, and how many chapatis are you eating, and what about your diet, something like that. On examination, there's a generalized tenderness in the back. There's no localized tenderness, there's a generalized tenderness in the back, and there is a swelling without any local signs of inflammation. You all are aware of the signs of the inflammation: MBBS, second year pathology, general pathology, chapter inflammation, revert, tumor, dolor, calor, functional leso, Celsius Varsho. I think I've just, brought those memories. So there's just a swelling, there's just a tumor. There are no other signs of hotness. Blood counts, there's a raise in ESR, but yes, other counts are normal. X-ray has something like this. So, I mean, now you have to find out the diagnosis. I have simply put up here that, it's a intervertebral disc collapse, or a port spine, or a fibromyalgia, or a spondylolisthesis. What do you think about the diagnosis? Young chap, backache, 2 months, loss of weight, loss of appetite, generalized tenderness, no other signs of inflammation, and ESR is raised, other things are normal, X-rays like that. So guys, what do you think about it? You have to immediately tell us the answers. So this is the X-ray. So, all right, so most of you are writing tuberculosis of spine. So what makes you say so? It is tuberculosis of spine. We have to understand right from the clinical picture itself. India contributes to, I think, somewhere around 1/3 of the global burden of tuberculosis. In India, whenever a patient of backache comes to my OPD, the first thing that is always there in my mind is whether there is any history of any precipitating event or not. So the first thing is any trauma, any weightlifting, any forward bending, any sort of a jerk. Is there anything mentioned like that? No. If there is any history of weightlifting or any sort of a jerk or any sort of that particular event, then the history should have been a couple of days, max to max 1 week. But here we are talking about a backache which is there for the last 2 months. So first of all, one thing is ruled out, that is acute prolapse intervertebral disc. Second thing, which is quite a possibility, is chronic intervertebral disc prolapse, of course. Then one of the options, if you remember, spondylolisthesis is one option, then fibromyalgia is one option. So we have ruled out one thing here, we have ruled out acute PIVD. All right, so depending upon the history, this is of no role now. So either it's a chronic PIVD or the rest of the options. Now I'll take you again. There is a history of loss of weight and loss of appetite. Cachexia, I'm sure you all have heard of it. Now, whenever I talk about loss of weight, loss of appetite, what does that mean? That means in India particularly, or rather anywhere, that means two things. A, it's a malignancy. CA, cancer. Second thing, what it signifies, tuberculosis. So now I think that probably it is TB spine. So something is going on here. Now there is a generalized tenderness. There is a generalized tenderness. Generalized tenderness is a beautiful feature of this non-specific fibromyalgia. But generalized tenderness is not a feature of spondylolisthesis. So there is one thing which does not go into the favor of spondylolisthesis, is generalized tenderness in listhesis. Usually there is one particular level which undergoes listhesis. You see kind of a tenderness which is localized to one particular site. Now, when we talk about blood counts, okay, now there is a swelling without any local signs of inflammation. Guys, if you remember MBBS, final year surgery, practical manual, we all bought that book. We all read that, with a lot of enthusiasm and shiddat. That was S. Das. You remember abscess? You remember cold abscess? Why it is called cold? Because there are no other signs of inflammation. There are no other signs of hotness. So that is something which I have written here. So there are no other signs of inflammation. And cold abscess is something which is a hallmark of tuberculosis. So now, the clinical stem, whatever we have read till now, it is taking me towards tuberculosis. Anyhow, still, we can see something else as well. ESR is raised. All other counts are normal. So, of course, that is again suggestive of tuberculosis. Now, let's talk about that. Do you see any slippage of one vertebral body over another vertebral body? Do you see slippage of one vertebral body over another vertebral body? No, you don't. So, technically, I don't think that it is spondylolisthesis. I don't see any clinically obvious spondylolisthesis. For a spondylolisthesis to be an answer, they will show you an X-ray which will have at least more than 50% of the listhesis. So now option can be chronic PIVD, TB spine, fibromyalgia, but in chronic PIVD, I don't expect some sort of a swelling with without other local signs of inflammation. So I'm not even taking that into consideration. So either TB spine or fibromyalgia. What do you think, this particular thing is giving rise to? Dr. Sumer will highlight all these features that, what has happened here. And of course, many other X-rays will be shared with you. And then you will also, come to the conclusion with all of us that it is tuberculosis of spine. Over to you, sir.
I think, Dr. Tushar, you have covered a great case so far, and I'll also request that once the X-ray finding is done, I would want you to talk about the treatment of this disease also, because I think that will help a lot of students. Now, what we saw in the X-ray is, very, very important, that you saw a reduced disc space. That is one of the findings that you could see in a degenerative disc disease as well as in tuberculosis. But when you saw reduced disc space with the entire clinical picture in mind, you know that, we were looking at tuberculosis. What I'll do is I will share my screen and just go full screen for you. I hope you are able to see my screen. So what I'm going to do is I'll do a quick roundup on what all is possible when you look at a radiological picture of tuberculosis. So first of all, I want you to be familiar with the anatomy of the vertebra. This is how axial section, axial 3D image of the vertebra would look like. This is your body of vertebra. Okay. This part is called as the pedicle. This is the vertebral canal or the spinal canal. This is your spinous process. And I'm sure you know this. I'm just trying to be sure on everything. This is your transverse process. Okay. And these are your articular facets. Okay. Now, and behind this, you also see the posteriorly, this is your lamina. Now, when you talk about tuberculosis, we know tuberculosis, when we talk about it, it is a pulmonary involvement, but it can go to the bone and it can cause skeletal involvement, and vertebra are a very favorite site of tuberculosis, especially the vertebral body. This vertebral body is very vascular, has, cancellous bone and bone marrow. It is very vascular. So this is where you would look for tuberculosis mostly in the vertebral body. However, not saying that it cannot involve the posterior elements. It can also involve the posterior elements, which would be less common as compared to the involvement of the vertebral body. I hope this is clear to you. The second thing I want you to see is this is how a vertebra in 3D would look like on a sagittal section. This is your vertebral body, and in between you have the disc. Now, tuberculosis is a hematogenous infection. it reaches the vertebra via blood. I hope everybody is clear. It reaches the vertebra via the blood. So there are two kind of blood vessels that you would have. You would have arteries, you would have veins. That means this tubercular infection, the Mycobacterium tuberculosis, can reach the vertebra via the arterial supply or via the venous drainage. So both of them are possible. So let's try to understand this. Now I'm trying to explain to you what you saw in the X-ray. Now the vertebral body are formed by the vertebral body and disc complex is formed by sclerotomes and notochord. This notochord is going to form the nucleus pulposus. Notochord is going to form the nucleus pulposus, which is the pulpy central part of the disc, and the sclerotome will form the vertebra. So one sclerotome actually forms inferior part of one vertebra and superior part of the lower vertebra. So a sclerotome is going to form the vertebra, inferior part of one vertebra, superior part of the vertebra below, and in between the annulus fibrosus. That is what the sclerotome is going to contribute to, and the nucleus pulposus is going to be formed by the notochord. Now, because this sclerotome would have a common vessel, it would have a common blood supply, so the blood supply of the inferior end plate of one vertebra and the superior end plate of the vertebra below will be common. Okay, will be common. Now let's try to imagine again. Suppose these are your two vertebra. What we have learned by now is that this part of the vertebra and this part of the vertebra have common embryological origin. So they will have a common sclerotome. So they would have a common blood supply. And we have already discussed in our class so far that tuberculosis is a hematogenous infection. So it will arise from the artery, and artery will go into both the parts. So that leads us to a conclusion that most often tuberculosis of the vertebra would involve this area. That means it will involve the part of the vertebra around the disc, which will be called as paradiscal. Okay, so pathologically speaking, it is the vertebral body which is getting involved. It is the vertebral body which is getting involved because of tuberculosis early, not the disc. Okay. So, but what will happen is, because whenever there will be some vertebral destruction happening here, you need significant amount of destruction to happen before it becomes visible on X-ray. So what we actually see is, because there is paradiscal involvement, okay, and disc in children, I want everybody to understand this is very technical and very interesting also. Disc in children has vascularity. In adults, it is primarily avascular. So when in children you see tuberculosis, you see early involvement of the disc because disc has vascularity. So hematogenous infection, the vertebral end plates are involved as well as the disc is involved. Are you clear? But when you look at in children, you will have discal involvement early as compared to adults. Okay, in adults, it is primarily the involvement of the vertebral body, primarily the anterior part of the end plate here. This would be involved early, but we will not be able to see it on the X-ray. What will happen is, when there is paradiscal involvement, the vertebral end plates become weak and the nucleus pulposus herniates into the vertebra. There is reduced nutrition going into the disc plate and the disc space reduces. So let's come to the first MCQ on radiology here. Earliest X-ray feature of port spine is, what is your answer? Loss of disc space. And I'll ask, Dr. Tushar also to, maybe add on a line here. I think it is a worthy point here. So Tushar, I think you can also add a line here that that earliest X-ray feature is loss of disc space. But that is not the earliest part. Disc is not the earliest part which is involved here. I think, a lot of students keep getting confused here.
So as Dr. Sumer said that, he explained it to you that how the embryology happens. What sir emphasized on the fact is that spine develops from a somite. Somite develops into a sclerotome, martome, dermatome, and spine develops from a sclerotome in such a way that upper half of the lower body, lower half of the upper body, and the descent intervertebral disc, they develop from a single same somite. Now, since it is coming via hematogenous route, the organism can enter into either of the three. So it can enter either into the upper body or the lower body or the descent disc. But by the virtue of the infection, it usually, as are told, it enters usually into the body. So when it enters into the body, where does it enter? Is it the center of the body? No. Is it the periphery of the body? Yes. Is that part adjacent to the disc? Yes. So is that the peripheral part of the body which is adjacent to the disc? Yes. So that is why the lesion is called paradiscal, para-adjacent discal disc. So technically, pathologically, the first part to be involved is vertebral body, though it is the peripheral part which is adjacent to the disc. But just now you've been told that the first X-ray feature is reduction of the intervertebral disc space. So this is one question that keeps coming in every now and then on all the sorts of social media platforms. That, sir, in your notes you told us that the first part to be involved is disc. Agreed. Next page in your notes it is written that the first X-ray sign is reduction of the disc space. How is that possible, sir? The first X-ray sign should have been in the body, or the first finding that should have been in the disc. So why there is a kind of a mismatch? Please answer. Matter of our career. So what is the answer to that? A simple answer to that is minimum. I mean, this is something that I'm quoting from a standard textbook. The standard textbook belongs to the god of Indian orthopedics, Dr. Surinder Mohan Tuli, Dr. S.M. Tuli. So he is allegedly, the father of osteoarticular tuberculosis. So in his book, there's a line which is clear-cut. It is written clear-cut that minimum 30 to 35% destruction of the vertebral body has to happen to be evident as the first X-ray sign. But you know what? Before that 30 to 35% of the destruction happens, actually the disease enters into the disc. So by that time, the changes in the disc, they become obvious, they become evident to Dr. Sumer. Before that becomes evident to me or to the disease process per se pathologically. So pathologically, the first part to be involved is body, but radiologically, the first part to be involved is disc. The first sign has to be seen in disc. There is one more confusion that roams around here and there, everywhere, because of some guidebooks, is that, sir, there it is written that the first X-ray sign is loss of spinal contour or a loss of spinal curvature. You know what, guys? You attend a 5-hour lecture. After that, when you will wake up, you will get up, you get an X-ray, you will have a straightening of the spinal curvature. Straightening of the spinal curvature is a very non-specific finding that can happen at any point of time whenever your paraspinal muscles are in spasm.
Sure, I'll request, maybe you can share that X-ray again. I think we can see that X-ray of your case. Maybe we can show them what is that straightening.
Yes, sir. Yes, sir. Just a minute. Oh, okay. First, I need to. Yeah. Can I share? Yeah. Now I think I can do it.
Yeah. Done.
So,
okay, so I think, when you see this straightening, now normal spinal curvature in the lumbar area should be lordotic, in the thoracic area it should be kyphotic. But if you see, this is all straightened and that is spasm. But I agree with Dr. Tushar here that this spasm is non-specific. It would occur in any cause of backache. You will have that kind of spasm. It is not just because of tuberculosis. I think Dr. Tushar, continue, please.
So that was the point that I wanted to clear, that straightening of the spine might be the first X-ray picture, but it is not a specific one. It is not a classical one. It is not the hallmark, not the diagnostic, not the pathognomonic. So the first classical X-ray sign is always reduction of the intervertebral disc space. Although pathologically, the first part to be involved is vertebral body, and definitely that's the periphery of the body, which is adjacent to the disc, and that is why the lesion is what is called as paradiscal. So that was the point that I wanted to mention here. Over to you, sir.
Okay. So now let's continue further. So we've, I think we've covered some ground. And on this ground, I think most of you would also agree here that X-ray will not be the investigation of choice in cases of tuberculosis. The reason X-ray will not be the investigation of choice here is because, as Dr. Tushar mentioned, and we all talked about it, that 30 to 40% destruction is required in the vertebral body to be evident on a X-ray. So X-ray will show us the disc space loss, which would actually occur a later part of the disease because the vertebral involvement is the earlier part. So if I now say, X-ray cannot show me the pre-destructive stage of tuberculosis. Are you able to understand the point here? X-ray cannot show me the pre-destructive stage of tuberculosis, and that is why we do MRI as the investigation of choice. I'll talk about this at length and I'll show you images also. But I hope you start getting the feel of it, because in our integrated rounds, the purpose is to give you the concept so that you don't have to mug up and you think, sir, wahan ye likha hai, yahan ye likha hai, because in the end, you are becoming doctors. You're not going to become the, you can't tell to a patient कि उस guide में ये लिखा था इसलिए मैं ऐसा कह रहा हूँ. Pre-destructive stage of tuberculosis will not be seen on X-ray. It will be seen on MRI. Are you clear? Okay. Second part of my discussion is that we also know that there is also a venous plexus. You have a external venous plexus, internal venous plexus in the around the vertebra, which you know that is the valveless system of Bateson plexus. Now imagine if the infection reaches the vertebra through the vein, then what will happen? If the infection reaches the vertebra through the vein, what will you see? You will see involvement in the center of the vertebral body. Okay, so if the infection reaches the vertebral body through the Bateson plexus, through the this entire venous plexus is around the vertebra, it will involve the center of the vertebra. Okay, and that leads me to a second pattern that is possible here, which is called as the central pattern. So we saw a pattern which was paradiscal, which is the classical, but you can have another pattern if the involvement is because of the venous spread of the tubercular infection into the center of the body, that will be called as central. Now what will happen is this infection will keep destroying the vertebra, in a circumferential manner, and ultimately the entire vertebra will collapse. And when the entire vertebra will collapse like a disc like this, it will become plane. We will call it vertebra plana. Okay, so even before we look at the X-rays, we have some basic idea in our mind. Okay, if tuberculosis is the central type, it can lead to circumferential weakening of the vertebral body, and then that vertebra will collapse and it will become totally flat. That is different from what would happen in paradiscal tuberculosis. Try and imagine, in paradiscal tuberculosis, TB is weakening the anterior part of the vertebra. It is weakening the anterior peripheral part of the vertebra. So when that collapses, you develop a wedge collapse. You develop wedging. So wedging means the anterior part is collapsing more than the posterior, and you get kyphotic deformity of the spine. Are you clear? But in the central part, you get vertebra plana. The importance of this is that in children, vertebra plana is because of a hematological or a pathological disorder called as histiocytosis, which is called as eosinophilic granuloma. So that becomes a DD, differential diagnosis. And in an old person, it could be because of multiple myeloma or metastasis. So remember, vertebra plana, solitary vertebral collapse with preserved disc spaces is possible in tuberculosis in the central type. But remember, that is, then you have to consider the differential diagnosis of eosinophilic granuloma in a child would be the most important DD here, and multiple myeloma and metastasis would be the DD in the adult. Now let's go a little further. Another point that is important for us as far as radiologists and orthopedic surgeons are concerned, that we also need to know the anatomy of the spinal cord. This is the anterior part, this is the posterior part. All I am here telling you here is the anterior part, you have the anterior, and the lateral part, you have the motor area, you have the motor corticospinal tracts. Okay, and the light touch is in the anterior part, pain temperature in the lateral part, and the deep touch proprioception in the dorsal column. So it is important to understand when there will be vertebral collapse, when there will be kyphosis, there will be epidural abscess, it will compress the anterior part of the column. So that will explain the symptomatology that would happen in the patient. So with that in mind, I'll just quickly show you what is the possibility with the MRI and what we are able to do. Let's with that background in mind, just I want you to look at these 4 images together. I'm removing the label first. Look at this image. Okay, this is a stir MRI image. Stir means we have suppressed the fat signal. So the bone and the bone marrow are appearing dark because the fat has been suppressed. Despite suppressing the fat, this vertebra are contiguous vertebra are appearing bright. So there is bone marrow edema, and intervening disc space is, you cannot appreciate the intervening disc space. So what do you think this is? This is paradiscal variety of tuberculosis that we already talked about as the more common one. Look at the second pattern here. You have the edema in the center of the vertebral body, but the disc is preserved. The intervening discs are not involved. This is the central type of port spine that we talked about. Now, the third type of port spine that I wanted to talk about is, we are now able to understand that TB in the initial part would involve the peripheral part of the vertebral body here. Okay. Then you also know that in anterior to the vertebra, I'm sure you know this, there is a ligament called as the anterior longitudinal ligament. There is a ligament called as the anterior longitudinal ligament. Now, Mycobacterium tuberculosis is different from pyogenic infection. Pyogenic infection is usually having proteolytic enzymes, so it causes a lot of destruction. While tuberculosis, the tubercular bacteria lacks proteolytic enzymes. So what will happen is this abscess that is going to form here, the destruction that will happen will not destroy the anterior longitudinal ligament. This abscess will start to spread below the anterior longitudinal ligament, below the periosteum here. And that gives rise to a pattern called as the anterior subperiosteal or the anterior type of tuberculosis. So it is spreading below the anterior longitudinal ligament, below the periosteum, and it is not destroying them because it is lacking the proteolytic enzymes that the bacteria doesn't have it there. And because of this, the vertebra, they show anterior scalloping. So in the anterior type of tuberculosis, I will show you the MRI also so that we get a picture. Now see, so in the anterior part of the TB, in the anterior type of the TB, you see scalloping of the vertebral body, and you can see the abscess is, spreading in front of the vertebral body like this. This is how the anterior type of tuberculosis would look like. And third and the rarest type is the involvement of the posterior element. Here you can see there is involvement of the spinous process. You can see involvement of the spinous process, along with there is involvement of the epidural space. Okay, so let's revise now. Radiologically speaking, tuberculosis of the spine usually is paradiscal, but can also be central, can be anterior, can be posterior. Least likely format will be posterior involvement. Okay. Now, what do you think the examiners expect you to see? The examiners are more happy to give you sometimes X-rays and ask you what are you able to see in this X-ray. Anybody wants to tell me what is the X-ray finding here? When I zoom the X-ray, between this and this vertebra, there is loss of disc space. Are you able to appreciate this? Okay. So there is a loss of disc space. Loss of disc space could be because of multiple reasons, but here we have something extra which is pointing towards the diagnosis of tuberculosis. Anybody? You have paraspinal shadow. I want you to appreciate. This is called as paraspinal abscess. Now, we can even think about, as a radiologist, that do you think this abscess is under tension or not? If the length is more than the breadth, this is how a fusiform shaped abscess would look like. However, sometimes we see abscess where the breadth is more than the length, that is more globular, so we'll say it is more under tension. So we are able to think on those lines when we look at a paraspinal abscess. So we saw, so far we have learned loss of disc space is a characteristic radiological picture that you see in tuberculosis. Second is paraspinal abscess. Third thing we have learned is MRI will be able to show us bone marrow involvement, edema, earlier than the X-ray. So MRI is the investigation of choice to diagnose tuberculosis before the destruction happens in the pre-destructive stage. Are you clear? And paraspinal abscess, not only you will see in the thoracic area, you can also see in this particular case. This is a previous X-ray shown in JIPMER exam. Here you can see the paraspinal abscess is, as I go towards the neck, it is diverging. It is not converging. That means it is not limited to the thorax. It is a cervicothoracic sign is there. It is involving the cervical as well as the thoracic area. And so we can see paraspinal abscesses. These are like typical images in your exam. This is a paraspinal abscess in the dorsal area. This is a paraspinal area in the cervicothoracic area. But also remember, if you ever see calcification in the paraspinal abscess, I'm again repeating, third X-ray picture is calcification. If you see calcification in the paraspinal abscess, it is almost diagnostic of tuberculosis. So keep this in mind. If they ever say, show you a psoas muscle which is calcified, a paraspinal abscess which is calcified, it is typical of tuberculosis. There is no other differential diagnosis once you see calcification. Okay. Okay. Third thing that you can see is, I want you to appreciate this X-ray here. Both sides of the vertebra, I will try to draw a line also. Both sides of the vertebra, This is how you have the Schwarz line. Okay. When you look at an abdominal X-ray on both sides of the vertebra, this is how you should see the Schwarz line. Imagine now if the abscess, now what is happening? Dr. Tushar talked about that in this disease, you will have cold abscess. That means abscess will not have the inflammatory signs. It may be away from the actual focus of infection. So you have a tubercular disease in the spine, but the abscess is tracking down along the ribs, or it can track down along the Schwanz muscle. It can track down along the brachial plexus. So it is tracking away from the origin of the disease. So very important for all of us is, sometimes I'm doing an ultrasound of a patient and I see a Schwanz abscess. Immediately I advise a X-ray to look for pot spine, so that I can, tell the surgeon who has advised that, okay, this is not a surgical, this is probably an orthopedic case, there is a spinal tuberculosis. Because once I see Schwanz abscess, I start thinking that maybe there is a concomitant tubercular spine as well. So how will I see it? Now I want you to appreciate this particular X-ray. This is the Schwanz line here, and this is the bulging Schwanz shadow here. Okay. Are you able to appreciate on the left side in this particular X-ray, the Schwanz is bulging? So this is how you think of Schwanz abscess on an X-ray film. The normal line should be more oblique, more straight. Here it is more bulging. This is how a Schwanz abscess would look like on an X-ray. The third thing here is, I will show you another example. Again, see this bulging Schwanz line on the right side here. Again, a Schwanz abscess. So we are able to think on those lines that, okay, we have so far seen, I'll try and give you the picture again. We have seen that, okay, tuberculosis of the vertebra can be mostly paradiscal. You will see loss of disc space on the X-ray with adjoining soft tissue. Okay, very, very important. So adjoining soft tissue means abscess, and that is one of the more important findings here. Are you also able to pick up the Schwanz abscess on a CT scan? This is how the normal Schwanz muscle should look like. And I want you to compare it to the right side here. What do you see? Do you agree that we have that same bulge here? Do you see that same bulge, same heterogeneity here? Okay. So this is how a CT scan of the Schwanz abscess would look like. Okay. And not only the abscess is not only seen in the Schwanz and the abdomen and the thoracic, you will also see it in the prevertebral area in the cervical spine. In the cervical spine, we roughly say that above the level of cricoid cartilage, prevertebral soft tissue normal will be around 5 mm. Below the cricoid cartilage, 15 mm. Okay. In a normal person, there would be different figures in children and adults also, but we can roughly remember that above the cricoid cartilage, the 5 mm is the normal thickness of the prevertebral soft tissue. Below the cricoid cartilage, 15 mm. I want everybody to look at it. This is a very important NEETPG image. It will be asked in your exam. Anybody wants to tell me? What do you see here? Any child, any smart child here, and all smart Damsonian, anybody wants to tell me here? There is widening of the paraspinal prevertebral tissue. This is definitely more than 1.5 centimeters. This is like more than an inch actually. So there is paraspinal soft tissue. Now I will zoom it further. When you zoom it further, you can even see, I'm so sorry, you can even see there are air loculi in that area. Okay, I will just go back. There are air loculi in that area. Can you see that here? Okay, so again telling you that is an abscess. And then when I look at it with a smart eye, are you able to see this is your C2 vertebra? Okay, C3 vertebra, C4. Look at this disc. What has happened? There is loss of disc. So again, we see two combinations, loss of disc space, surrounding abscess, surrounding soft tissue, telling me that, okay, this is tuberculosis. Okay, so we can see there is prevertebral abscess with loss of disc space. This is what you're supposed to do. Like, see, try and understand. An average radiologist will be able to pick up the abscess. A good one will also be able to pick up the loss of disc space and tell you the complete diagnosis that this is tuberculosis of this area. Interesting? Okay. So going forward, MRI is the investigation of choice. I just wanted you to recall from my class, in MRI, we have T1 weighted image, T2 weighted image, STIR that I talked about, and contrast enhanced MRI. Okay. So I am sure you already know it by now, or you will know it in further classes. To see bone marrow edema, we use a MRI sequence called as STIR. Okay. But also remember, whenever you have TB, the surrounding soft tissue that you see, okay, the surrounding soft tissue that we see is not necessarily abscess. It could be two things. Either it is abscess or it is granulation tissue. It is all the, soft tissue with granulation tissue. So when I give IV contrast, abscess will show peripheral rim enhancement. Granulation tissue will show more homogeneous enhancement. So MRI, if they ever ask you in the exam, okay, listen to me everybody, if they ever ask you in the exam, what is the investigation of choice for Pott-Smyne? The answer is MRI. If they ever say plain MRI or contrast MRI, the answer is contrast MRI. Because an abscess will show peripheral rim enhancement while the granulation tissue will show homogeneous enhancement. Okay, are we clear? Okay, so this is how T1 weighted MRI looks like. I want everybody to see the normal vertebra. See this normal vertebra here. Can you see the bone marrow signal here? Okay. And can you also see there is abnormal signal in contiguous vertebra here? Contiguous involvement, talking of a disease which is spreading. You remember I showed you how tuberculosis was spreading below the anterior longitudinal ligament involving the contiguous vertebra. So these contiguous vertebra are involved, and you can see there is soft tissue anterior to it showing the spread of the disease from this. So this is typical tubercular involvement on a T1 weighted image. When I do T2 weighted image, the fluid becomes bright. On a T2 weighted image, I'm sure you remember from my classes, the fluid becomes bright. So now what will happen? Abscess. Now, can I ask you, if you look at this, are you clear now? There is involvement of the vertebra, there is loss of disc space, but the abscess is present anterior to the vertebra as well as posterior. Where is this abscess located? Where is this abscess? Okay, where are my yellow arrows? Anybody now? Tell me. It is epidural. It is in the spinal canal. So you can also see the spinal cord is actually showing spinal cord compression. And if you zoom it further, you can see there is abnormal signal in the cord. You can see there is, now the cord is starting to get involved, and you can see it is going to be the anterior part of the cord that will be involved here. Okay. So you can see there is epidural abscess as a result of tubercular involvement. There are 4 contiguous vertebrae involved. There is loss of intervening disc. There is abscess. Okay. Now I'll show you another example of how it looks like. Now, coming back to the terminology, please see this axial image of MRI. Abscess, you can see here, this is prevertebral abscess, prevertebral. But what you see on the side of the vertebra will be called as paravertebral. So we will use a term pre and paravertebral abscess. Okay, are you able to see this? Can you see in front of the vertebra and on the side of the vertebra there is abscess? But also notice, and that is what you are being paid for as a doctor to tell, there is also abscess in the spinal canal. So there is epidural abscess as well. So you have pre, para, epidural. So you remember now, inflammation, the infection started in the vertebra. From the vertebra, the infection can break through anterior to the vertebra, prevertebra, on the sides, paravertebral, behind into the epidural space. Okay. And that is where, when you will, hear Dr. Tushar talk, he will also talk about that this abscess can lead to paraplegia. And that is where it is important to understand there are 2 reasons why a patient with Pott-Smyne can have paraplegia. Either it could be because of this abscess compressing the cord, or it could be the kyphotic deformity, the vertebra going backward, compressing the cord. And that is what Dr. Tushar will talk about when he talks about the management part. Another example of anterior abscess and multiple contiguous vertebra getting involved. And you can understand that giving the dye helps. This is a contrast enhanced MRI. I want you to look at the abscess that I have marked for you. Are you clear? This abscess is center part is dark and periphery is showing rim enhancement. That means it is an abscess. This is not granulation tissue. Granulation tissue in tuberculosis will be more homogeneously enhancing. It will not be rim enhancing. Peripheral rim enhancement means abscess. Okay. Okay. Although we do not usually, when I talk about TB, I will always talk about MRI, but there is some role of CT scan here. I want you to understand. I want you to see this fragmentary destruction of the vertebra. Now, when you see a pyogenic infection of the vertebra, the pyogenic infection has proteolytic enzyme. So it destroys the vertebra fully. TB lacks proteolytic enzyme. So you will see bony fragments, destruction in between the bony fragments which are not destroyed. So whenever I see on CT this fragmentary destruction along with abscess, it is pointing towards the port spine. Even today, we have ability to do 3D reconstructions and show you, and I'm sure you can appreciate in this patient, this is a complex kyphotic gibbous deformity. Very, you can see these vertebrae are actually fused and there is a complex kyphotic deformity which we can see on a 3D reconstruction. So coming back to the point, CT scan can help us to see the pattern of destruction. In TB, it is more fragmentary. It can show you the deformities with 3D reconstruction. And can anybody tell me what is being done here in this image? Can anybody from the chat box let me know what is being done and what is the reason we are doing this? Okay, now you can see here we are trying to point this needle onto the soft tissue. So there is some soft tissue around the vertebra and we are trying to do a CT guided biopsy. So let us, try and get in hang of it. Although the investigation of choice for port spine is MRI, but if you are in doubt, if you think probably maybe it's a neoplasm, it's a multiple myeloma, it's metastasis, how will you know it? How will you confirm? You need a biopsy. And to do a biopsy, you need CT guidance. So the gold standard, which you will use here, would be CT guided biopsy. But Dr. Tushar will probably, expand upon it more. But it is not the investigation of choice. Investigation of choice, as far as I'm concerned, would be MRI. Are you clear? So CT has a role in guiding biopsy in cases of doubtful concern. CT can also show us the same pre-paravertebral abscess. So this is this is the vertebra and this is abscess surrounding the vertebra, perivertebral area, pre and para. Para means vertebra ke side pe, pre mane vertebra ke samne. We are able to see the abscess here. Okay. And just a point to make before, I hand back to Dr. Tushar here is look at these two vertebrae. What has happened to them? What happens is when you give treatment to the patient, when the disease becomes more and more chronic, the vertebra which are involved by TB, they ultimately fuse and they form bony ankylosis. You can see there is two vertebrae which are totally fused here. This is a bony ankylosis of the vertebra that has happened. This is slightly atypical because when we talk about tuberculosis of the bone, usually we will say TB of the bone will not lead to new bone formation. It will not lead to bony bridging in other parts. TB that is the key differentiation between a pyogenic osteomyelitis and tubercular osteomyelitis. Tubercular osteomyelitis will not lead to new bone formation. Pyogenic will lead to new bone formation. But spine is an exception where you see that bony fusion or bony ankylosis of the vertebra that happens in the chronicity. And when you give the patient treatment, you start developing sclerosis, increased density, and bony fusion happens. But these are the DDs that we have to keep in mind. Number one is, could be pyogenic. It is not necessarily every infection of the vertebra and disc will be tuberculosis. It could also be pyogenic infection. But remember, pyogenic infection is far more proteolytic than the tubercular. So you will have early destruction of the disc space will be not very early. It will be totally destroyed. And you are able to think that, okay, maybe this is pyogenic. Second key word here is brucellosis. Brucellosis you should consider if they say a patient has undulant fever, or they will say a patient has proximity to cattle or maybe consuming non-pasteurized milk products. And in brucellosis, it is the anterior superior corner of the vertebra which shows destruction, along with later on develops osteophyte in that area that is called as the Pedro-Pons sign. So brucellosis is one of the differentials in a patient where the zoonosis, you can suspect zoonosis because of proximity to cattle or consumption of non-pasteurized milk product. Ankylosing spondylitis can mimic tuberculosis if you have enthesopathy, enthesitis of the end plate. It can look like tuberculosis, but the entire looking at the other parts of the spine where we see fusion and syndesmophytes, we are able to think of angspons. Rheumatoid arthritis involves the C1, C2 vertebra. And I want you to know that TB can affect any part of the spine, although we will talk about the more common areas, but it can affect any part of the spine. If you have rheumatoid arthritis of the atlantoaxial junction, it may mimic tuberculosis and vice versa. We might get confused, so we need to keep that in mind, and we need to look at the entire picture when we are thinking of a C1, C2 destruction. These junctional areas like craniovertebral junction or the cervicodorsal junction or sacroiliac joint, sacrum, these areas are very difficult to visualize on X-ray, further telling us the value of MRI in these cases. Metastasis, multiple myeloma will lead to vertebral collapses, abnormal marrow signal, and all this are differential diagnosis for a central type of TB. And don't forget, trauma or osteoporotic collapse can also lead to a single solitary vertebral collapse in an old man. On this note, I think I've given you the overview of the radiology and the differential diagnosis and how to go about it. I'll ask Dr. Tushar to take forward here. Tushar.
So guys, you understood the very basics of it. Now I'll just quickly take you through certain aspects of the disease. We'll talk about the management and certain other things. So Dr. Sumer has already spoken about the paradiscal lesion, the central lesion, the interior lesion. So I'll just give you a quick overview. So this is the paradiscal TB, where I told you that the disease will start at the part of the body which is peripheral adjacent to the disc. Just summarizing everything for a quick revision for all of you, it undergoes into arterial spread. The second one is the central TB, where the first part to be involved is center of the vertebral body. Sir has already spoken about Bracet, Betts, and venous plexus. Then we have the interior TB, which is usually the wet TB, the exudative TB, the more destructive TB, which spreads up periostally beneath the anterior longitudinal ligament, classically seen in children, and more of exudation and caseous necrosis happens. If you have attended my lecture, we have spoken about all of these things at length. Then you have the least common, that is the, as of now, the lesions, when we talk about them, the least common, the appendicular TB, which is actually involving the posterior column. Technically, it is very difficult for Mycobacterium tuberculosis to cross posterior longitudinal ligament, so that's the least common site. So technically, which is the most common lesion? Paradiscal. Which is here the least common lesion? Posterior. But in posterior, which is the further least common lesion? That is articular. When I say articular, what does that mean? That means facet joint. So least common is appendicular or posterior. In that, least common is facet joint. Maybe one day you have an MCQ and you don't have facet joint as an option. Then you have to know the second least common is, come on, speak up, spinous process. All right. So least common lesion posterior, in that least common facet joint, second least common spinous process, if at all facet joint is not given in the option. So this is an articular TB, a kind of an appendicular TB. Active stage, constitutional features, typical features of tuberculosis. थकान होती है, चपाती कम खाता हूँ, कपड़े ढीले हो गए, शाम को बुखार है, रात को पसीना. I'll say this in English again: malaise, headache, dizziness, fatigue, loss of weight, loss of appetite, night sweats, evening pyrexia. They may be present, they may not be present. They're not 100% going to be there. So what are the specific symptoms? The first symptom is always backache. The person is going to enter into your OPD and the first thing he or she is going to tell you, I have a backache. Most importantly, I sleep at around 11:30, 1:30. The pain wakes me up. Why? Night rise. In the night, you go off to sleep, your entire body relaxes, your muscle relaxes, tuberculosis from within starts creating backache. Then, of course, the first sign is you are going to examine. When you're going to examine, you're going to see a generalized tenderness. You're going to see a paraspinal muscle spasm. The next thing, sir, I'm not able to tie my own shoelaces. I'm not able to wear my own socks. I'm not able to wear and take off my own shoes. Last night, sir, what happened? My bike's key fell down. I could not pick it up. My wallet fell down. I could not pick it up. And my wife picked it up. And then after stiffness, I've explained it to you. I've explained this to you. And then deformity. Knuckle, gibbous, kyphus, restricted range of movement, can't bend down to pick my own stuff, a large lymph nodes, kind of a feature of tuberculosis. Abscess, sir has already spoken about it. But what is the biggest problem of abscess? That abscess has a tendency to travel along various neurovascular bundles and apart from that, muscle sheaths. 8-year-old child, he was diagnosed with pot spine, cervical area, C6, C7. A cold abscess was formed here. A swelling was there. No signs of inflammation. No signs of inflammation. There was a tumor, but there was no dolor, no pallor, no rubor. The family was told that it is a cold abscess. You have to aspirate it, anti-gravity. You remember final year surgery, SDAS? Always aspirate an abscess anti-gravity. Never do it along gravity. It will convert itself into a fistula. Go for anti-gravity, and then maybe we can instill streptomycin and isoniazid into it. This was explained to the parents, but the parents were like, doctor, come on, it's just a swelling, it's just a tumor, there are no other signs of hotness. You know what, an Indian patient is, Indian patient comes to you or is brought to you only because of one thing, pain. If there is no pain, they hardly bother. Never mind, even we did not bother. That cold abscess, which is formed in the posterior triangle of the neck, that started traveling into the anterior triangle and started compressing trachea and esophagus externally. Overnight, child went into what? Dysphagia or dinophagia, stride. So immediately anterior decompression was done, surgery was done. So that's the power of a cold abscess. Another guy, he had port spine of upper thoracic spine T5, T6. Cold abscess was formed over there. Ignored. Why? It was just a swelling. The wife constantly told him and to the doctor also, get it examined, and every time he used to just wear the shirt and ignore it off. But you know what happened? Cold abscess was formed over there in the upper thoracic spine. It traveled along the intercostal nerves and vessels to the retropericardial space, got burst over there, and it resulted into tubercular pericarditis, and later on the patient died. There was one more case. He had a port spine at the most classical area, that's the lower thoracic spine. Now, sir has already shown you about the psoas muscle. So that cold abscess started traveling along the psoas major muscle, and along with iliacus, it entered into iliopsoas, and which went into the left trochanter and therefore bottom line in the hip. So port spine actually complicated into what? Tuberculosis of hip. So one place tuberculosis resulted into another place of tuberculosis. Multifocal tuberculosis is one of the reasons for multi-drug resistance, and finally, eventually, we lost the patient. So that's the power of an abscess, which is actually not very hot but cold, so you have to be careful about it. Neurological deficit, paraplegia, we'll talk about that. Healed stage, this was active stage. Healed stage, all these constitutional symptoms won't be seen. But what is most important is pain will settle down, lymph nodes will settle down, abscess will settle down, stiffness will still be there, deformity will still be there, mobility will still be a problem, neurological deficit might be there. Basic investigations. I'm not going to talk about some Montoux or some acid-fast staining or Ziehl-Neelsen staining or some rapid bacterial cultures like BACTEC and MGIT, and that's for all microbiology people. I was just trying to show it off that, you know, even I'm an orthopedic surgeon, I know some bit of microbiology. So basically, when we talk about CBC, usually these guys are anemic. Lymphocytosis, lymphocyte monocyte ratio, we know as a classical biochemical hallmark for tuberculosis. ESR raised, an active stage of the disease, but a very, very interesting period that whenever, I mean, I'll show you a slide where I will tell you that what are the things to be seen when you have to analyze that your patient is on a mode of recovery or not. Normally, ESR over a period of 3 months suggest that yes, patient is on the road to recovery. Sir has already spoken about X-ray. I will just give you a brief overview. Sir has already spoken about an MRI, beautifully explained. But yes, CT guided biopsy is the gold standard. This is the investigation of choice, no doubt about it. No doubt about it. India contributes to, as I said earlier, almost 1/3 of the global burden of tuberculosis. India में क्या पत्थर मारो टीबी निकलती. So in India, it's okay, it's fine. I mean, I'll tell you what happens in India in most of the government places like government hospitals and OPDs. A young chap, backache, loss of appetite, loss of weight, evening pyrexia, night sweats. Okay, chapter closed. Don't even ask for an X-ray, prescribe him ATT. India ATT has become more of a hit and trial drug. Anybody whose fever is not settling down after a good effort of 2 to 3 weeks, most likely tuberculosis, give him ATT. So we get an X-ray done. Okay, fine. Now, we being at the tertiary care center, we get an X-ray done. Okay, fine. Then we get the MRI done. Okay, fine. But you know what? The Guras, the Western population who write our books, we don't have time anyway. So all these Western authors, they don't believe in MRI. I know MRI is the investigation of choice in India. We rely on MRI and we start our treatment. And not only we start our treatment, but we prognose the condition. We see the response to the therapy also. But all these Western authors, they say that if you have to have a gold standard investigation of choice, that should document the microorganism. You understand my point? They say that you have to document the microorganism. Do you ever believe that on an MRI you're going to see a multinuclear Langerhans giant cell with central caseous necrosis with a peripheral rim of mononuclear epithelioid cell? That's not possible. That's possible only on what? Biopsy. not an open biopsy. Again, various issues of sinuses and fistulas can create. So basically you have to go for a CT guided minimally invasive biopsy, but that is only in India, that is only for two reasons. One, if it is an MCQ. Two, if you are having a confusion regarding the diagnosis. And this is more common than, you know, confusion. Are you able to understand? Itna hame confusion nahi hota jitna MCQ aata hai. So CT guided biopsy is the MCQ, and this is just you know, theoretical MCQ. Any resemblance in practical life is just a coincidence. We are majorly governed in our OPDs by MRI. These are the investigations that has already spoken about them. Reduced disc space, you can see that. Blurring of the paradiscal margin, you can see that. Destruction of the body, you can very well appreciate that. Loss of the entire trabecular, there is an increased the prevertebral soft tissue shadow. You can see, you know, movement of one vertebral body over another vertebral body, and finally you can see the curvatures are exaggerated and lost. Sir has already spoken about them. Now let's talk about the staging was given by Dr. R. Kumar, Dr. Jain, Dr. Goel, but you know, Dr. Tuli is famous for this staging. He has given 4 stages. I'll just give you a clinical presentation of these 4 stages. First of all, OPD, next patient, please. Yes, sir, tell me. Doctor, I'm a patient of port spine. Okay. So doctor, I was diagnosed by you 1 month ago and you prescribed me bed rest and ATT and all those things, and you asked me to come for a follow-up after 1 month. Oh yes, fantastic. Tell me, how about today? Yeah, doctor, I'm fine. Any neurological deficit? No, doctor, nothing that I'm aware of. No, doctor, nothing that I'm aware of. No motor deficit, no sensory deficit. Wonderful. Just lie down. Just lie down. Take out your shoes and socks. Why, doctor? Of course, I'm going to see an MCQ. Which MCQ? That one which is taught in final year MBBS neurology, usually the ward rounds. You remember this word? PJ Mehta, Kundu, Dr. Achin Mehra, clonus. You remember we see clonus at 2 areas. One is patella, one is ankle. Patella, when you push patella, it goes like that is patella clonus. You push ankle dorsally, it goes like dig. That is ankle clonus. So I've asked him to take off his shoe. So why? I have to see what? Ankle clonus. The moment I see ankle clonus, the first thing that I tell to my patient, sir, congratulations, sir. Why? MCQ. Why? Sir, you have an MCQ, sir. This is the first sign of POTS paraplegia, sir. That means spasticity has started, sir. Planters are extensed, sir. Spasticity has started, sir. Spinal cord has started getting involved, sir. You are stage 1 POTS paraplegia, sir. Patient says, doctor, you know what? I came to your OPD on my own. I'll be leaving your OPD on my own. Do you even bloody know what paraplegia means? Paraplegia means paralysis. I'm walking without any support, and you call me paraplegia? Then you're like, sir, sir, I can't help you much because the staging has been given by these people. 5 days later, yes, tell me, doctor, I'm that same guy. Okay, tell me. So what is the problem today? Doctor, actually, now I'm aware of what? That I have an issue. Okay, what makes you say so? Doctor, actually, you know, I can still walk. I'm a typical patient. I can still walk, but I have to have a stick or a crutch or a support of a wall, furniture, anything. So even now, patient is ambulatory, but with support. In stage 1, patient was completely ambulatory without support. Rather, he was not aware of the neurological deficit. In stage 2, he is aware, but still he's ambulatory with support. But one good thing is that his sensory system is absolutely normal. But one thing is for sure, that what has started in stage 2, motor loss has started. I told him that, dude, you know what? Right from port spine, you entered into stage 1 POTS paraplegia. Even at that point of time, you were an indication of surgery, but you didn't listen to me. Now from stage 2, you have complicated into from stage 1, you have complicated into stage 2. You are an indication of surgery even now. Please get it done. He's like, no, doctor, don't worry. I will do this, that, but no surgery. Okay, fine. Another 5 days later, next patient, please. But the receptionist tells you that, sir, the patient cannot come inside. He's on a stretcher. You have to come outside. Okay, fine. So I went outside. I could see a patient lying non-ambulatory on that stretcher. He's lying non-ambulatory on that stretcher, and he's not able to walk. And there is a paralysis in extension. So the limbs are almost of this sort. So there is a paralysis in extension. Now, the most important part that happens in this stage is, like in stage 2, you had a motor loss. In this stage, you have a sensory loss that has started. So now sensory loss has started, even though one good thing is it is less than 50%. So I told his family members that, guys, you know what, he's further deteriorated. Let's get him operated. They were like, doctor, you don't worry about that. We're taking care of that. This happens in India. So it's fine. Another 5 days later, he's lying outside on the stretcher all alone and crying. I went outside. I said, what happened? He said, paraplegia. But this time it is in flexion. I said, that's fine. But why are you all alone and why are you crying? He said, my sensory losses, which was less than 50% in stage 3, is now more than 50%. I said, fine. I know it was supposed to exaggerate, but bloody hell, why are you crying? He said, doctor, Hambolna. He said, doctor, my sphincters are not working anymore. No voluntary control over urination, no voluntary control over defecation. At times I am soiling the bed, at times I'm making it wet. My wife and my family said, enough is enough, we can't bear this anymore. So doctor, that's why I'm here. They've brought me here. And now I need your help. What help? Doctor, surgery. Oh, surgery. You want to get surgery done. I told you in stage 1, you didn't listen. I told you in stage 2, you didn't listen. I told you in stage 3, you didn't listen. And you want surgery now. You want surgery now when your motor tracts are gone, when your sensory tracts are gone, when your sphincters are gone. What do you want me to do in your surgery? Should I play with bloody or dura mater, or should I just juggle with your CSF? So it is a stage 4 and almost a kind of an irreversible stage where you see not only the complete motor loss, you see the sensory loss more than 50%, and you see the most important part, the most irreversible part, that is sphincter issues. What are the basic principles of management? You can expect a good outcome only and only if you do an early diagnosis. The most important part is if you do early diagnosis. When I say early diagnosis, that means you have to be very prompt. You have to be very prompt. B, you have to have a very good hold over the medical treatment. Why? I'm telling you not because my textbook says, not because anybody says, I'm telling you with the virtue of my own clinical experience. ATT has got one of the finest penetration on osteoarticular tuberculosis. My physician friends, they talk amongst themselves. Dude, I saw MDR TB, multi-drug resistant. Another one, dude, I saw an XDR TB, extremely drug resistant. Third one comes, I saw very extremely VXDR TB. And Tushar, what about you? I said, cheers. Because I know that 90 to 95% of the cases of musculoskeletal tuberculosis, they are going to show a wonderful response to ATT. If at all a surgery is required, bloody hell, it should be timely and aggressive. And at every single point of time, you have to ensure that you have to prevent the deformity. How? I'll tell you. So with ATT, of course, I'll talk about ATT, but with ATT, I am a personally very firm believer of the supportive treatment. This is the most important part. Rest is the best here. I'm telling you, rest is the best here. You prescribe ATT to a person, I'm telling you, if the person is not going to take an adequate enough bed rest, that ATT is not going to work. So that's something that I always write in my prescription: absolute, strict, complete bed rest. To get up from the bed only for 2 things: A, to eat food; B, for the nature's call. Simple, straight and clear. Braces. And I hope if you have attended my lectures, I have already told you that whenever something called as T for trauma or T for tumor or T for TB happens in T for thoracic spine, we have to give T for tailless brace. You remember that? T for TB, T for trauma, T for tumor, and T for thoracic spine, you have to give T for tailless brace. High protein diet. But one thing you have to be very careful. There's a drug that we use in ATT. You remember paracetamide? What it leads to? Increase in the uric acid. So you have to be very careful with this high protein diet. Multivitamin, hematinics, hygiene, back care, chest, UTI, improve immunity, and treat any diabetes or hypertension, anything along with that. So this is the supportive treatment. I just wanted to let you know, not because of some sort of an MCQ, but basically just issued in public interest. So now if you have a case of a spinal TB, then there is a conservative treatment with chemotherapy only, with ATT only. There's a radical surgery, but now my focus is on this because this is given by Indians, middle path regime. So the first line chemotherapy, I'm no authority on pharmacology, but still I'm just trying to venture into that. So, okay. So bactericidal drugs, there's a first line ATT. We all are aware of the first line ATT, HRZDS. So except for all are bactericidal. So except for ethambutol, all are bactericidal. And the doses are given here according to the per mg per kg body weight. So bacteriostatic is only ethambutol, rest are all bactericidal. Again, talking about my personal experience as I'm taking the lectures, I have the liberty to share this with you. I'm not a very big fan of this. Why? Injectable. Another reason, of course, nephro, neuro, ototoxicity. I'm sure you all are aware of those MCQs. You have read well in pharmacology, but I'm personally not in a very good favor of streptomycin in most of my patients because of the basic issue of injecting every day. So that is something I'm not very fond of. Rest, of course, I'm aware of them and I am very fond of them. These are the new drugs. I'll be very honest in telling you that I like these two. Leoflox, M50, Odioflox, 200 BD or 400 OD, wow. If you add these two to the first line ATT, that's a wonder mocktail. Now, rest of the drugs, if you can remember them, that's good. If you can't, that's even better. What is middle path regime? All tuberculosis cases should be first given a benefit of trial of conservative method, that is ATT, simple. Every patient deserves to be treated with ATT at the first go. That is the fundamental behind middle path regime. Rest, we have already spoken about that, so there's nothing next, nothing new. Now the drugs protocol in middle path regime is ISO, NIA, rifampicin, ethambutol for 4 months, ISO PZA for 4 months, ISO rifam for 4 months, ISO for 4 months. And now you will get to know why I told you I am not very fond of streptomycin in my patients, because I've been trained and I've been taught and I've been nurtured by those professors who have been following middle path regime, where streptomycin is not documented as a very useful drug. So this is the treatment protocol. I mean, you can see it's a total duration of 16 months and the combination therapy is there. Supportive therapy, I've already told you, protein, hematinics and multivitamins. Every 3 to 6 months you have to monitor the X-ray and ESR, and after every 6 months you have to get an MRI for minimum period of 2 years. As soon as the disease part is sorted, the healing happens, you can mobilize the patient. Absolutely not a problem in that. Abscess, I already told you. I gave you the example of an 8-year-old child who had a cold abscess in the cervical spine. I gave you another example of a guy who had a cold abscess in the thoracic spine, then one in the lumbar spine. Very simple. If the abscess is superficial and it can be drained, you should. And then you can put a strepto or INS solution inside the cavity. Any abscess which is giving you any kind of obstruction of the vital structure. You remember 8-year-old child who had an abscess traveled from hair to there, from there to hair, and now it is causing difficulty in deglutition and difficulty in breathing. I told you, dysphagia or dinophagia stridor. So that has to be drained. So that is something which is written here. So any point of time, if there is any abscess which is creating any sort of a complication to any vital structure, be it trachea, esophagus, cord, muscle, anything, it should be drained, and then you have to put an ionized strepto solution into that. Tubercular sinuses. I mean, मतलब मैं क्या बताऊं आप लोगों को, India is so bloody full of this that, I mean, people have drained abscesses not even thinking that it can be a tubercular abscess. अब मेरी बात समझो. As a doctor, as a quack sometimes, as a just a jhola chap man, he saw swelling, he saw an abscess, he's not aware whether it is due to some pyogenic focus or some tubercular focus, and Leah played and catch. Now that sinus is formed. Why? Because it was a tubercular abscess. No documentation was done, no study was done, nothing was done, no investigations were done. So now you have a tubercular sinus. So this is something which is so common in rural India, I can't even tell you. So once you see that any sinus is assumed to be due to tuberculosis, unless and until proven otherwise. So all these usually they heal within 6 to 12 weeks of starting the treatment, and that is all about tubercular sinuses. Now, what are the absolute indications of surgery? Now listen, a guy comes to me, he has been diagnosed with port spine. I give him a trial of ATT for a period of 1 month, along with all those symptomatic treatment and everything. If he's not responding after 1 month, listen to me carefully, if he's not responding after 1 month, I should operate him. Now, he's not responding means what? A, his symptoms are stationary. B, his symptoms are worsening. He should be operated. His symptoms have complicated into neurological issues. He should be operated. He was already into stage 1 pars paraplegia. Despite being on ATT, he has complicated into stage 2. He should be operated. A guy was treated with a port spine. A guy of port spine was treated with ATT for a period of 16 months. Everything was fine. He got cured. Congratulations, congratulations. 3 months later, he comes back. I will not play ATT again for a period of another 16 months. I will operate. Pressure effects, deglutition, respiration, dysphagia or dinophagia stridor, I've already told you. Advanced paraplegic changes, stage 3, stage 4, I've already told you. So these are the indications of surgery where the symptoms, despite being ATT, are stationary or worsening, where they are complicating into neurological issues, whether neurological issues are themselves complicating, and whether there is a recurrence, whether there is a compression effect over vital structure, or whether there are advanced stages. So these are the usual sets of indications for surgery. Now, basically, when we talk about surgery, the surgery that we do is called, I'll show you the image also, anterolateral decompression with bone grafting. That's the surgery normally we do. After that, the patient has to be kept on a flat, hard bed. The patient has to be kept in a Taylor's brace for a minimum period of 3 to 5 months. Again, I repeat, T for TB, T for trauma, T for tuber, and T for thoracic spine. We have to apply T for Taylor's brace. And one should continue, Taylor's brace should be continued 1 to 2 years, particularly while sitting, while driving, while sitting on a bike or in a car. So you should continue wearing Taylor's brace, not whole day around, but yes, for some time, when you are expecting some sort of a jerk. So anterolateral decompression is the surgical procedure of choice. Anterolateral decompression with bone grafting. So of course, as the name says, anterolateral. So you don't enter anteriorly, you don't enter laterally, you enter anterolaterally. What is your aim? What is your goal? What is your maqsad? You have to go posterior, you have to go towards spine. So there is a rib which is going on like this. So what is the first part that you are going to remove in this surgery? What are the structures? What are the structures removed? What are the structures removed here? The first part of the structure which is removed is posterior part of the rib. Now guys, that posterior part of the rib, if you see, the posterior part of the rib, if you see, is actually making a joint here with the transverse process. So the second part that you are going to remove is called transverse process. By the way, this entire process is what is called as costotransversectomy. This was given by a guy called Menard. So Menard was one man who explained this process of costotransversectomy. So your posterior part of the rib is gone, transverse process is gone. Now you have to remove this part of the pedicle. Not you have to remove the entire pedicle, but you have to remove a part of the pedicle. Why? Radially, you have to have an access to the body. Now you can go to this part. You can go to the diseased body. You can go to the diseased body, and along with that, you can go to the intervertebral disc, which is already involved in the disease process. One very important MCQ, which has been coming in almost every exam. All of the following structures are possibly removed in the surgical procedure for port spine, except 4 options. A, rib. B, transverse process. C, pedicle. D, spinous process. Do you see me removing any sort of a spinous process here? Any kind of a lamina? So I'm not removing any spinous process, I'm not removing any lamina. So you have to be very careful with that. So this was about the treatment. Now, when we talk about follow-up, up to 2 years, you have to follow up every 3 months, particularly for improvement in the clinical outcome, particularly in the radiological outcome. MRI to be done every 6 months up to the period of 2 years. If the weight is coming back, there is a relief in the pain, the mobility is getting better. He's not able to wear his own shoes and take off his own socks. Abscess is getting settled. The neurologic is getting better. Radiological, all these things are happening. So that means, that the patient is on the road to recovery, probably healing or healed. So I think with this, I come towards the end of my presentation, and I think we have fairly covered not only the disease process part of port spine. We've spoken about the types of lesion. I'll just quickly sum it up. Paradiscal, central, anterior, posterior, most common paradiscal, least common posterior, and posterior least common. Facet joint, second least common. Spinous process, first symptom backache, first sign paraspinal muscle spasm. Now there is one thing that I want all of you to remember. One common mistake that you all do. I'm putting up 2 questions for you. First sign of port spine, first sign of port's paraplegia. Are you listening? First sign of port spine, first sign of port's paraplegia. Are port spine and port's paraplegia 2 different things? Yes. So what is the first sign of port spine? Tenderness. Paraspinal tenderness. But what is the first sign of port's paraplegia? What is the first sign of port's paraplegia? If you remember, ankle clonus. You remember? Ankle clonus. If that is not given in the option, then what? If that is not given in the option, then what? Come on, tell me. Extensor plantars. If that is not given in the option, then what? Spasticity. So I'm just summing it up again. So first symptom. So basically, most common lesion, paradiscal, least common, posterior. In posterior, least common, facet joint, least common, spinous process. First symptom, backache. First sign of port spine, paraspinal muscle spasm. First sign of port's paraplegia, ankle clonus, followed by extensor plantar, followed by spasticity. First X-ray sign of port spine, reduction of the disc space. First part to be involved in port spine, vertebral body. Although first X-ray sign of port spine, reduction of the disc space. Last X-ray sign of port spine, bony ankylosis. Investigation of choice, MRI. Gold standard investigation, CT guided biopsy. Are you able to understand this? ATD has got wonderful treatment. When we talk about port's paraplegia, stage 1, spasticity. Stage 2, motor loss. Stage 3, sensory loss. Stage 4, sphincter loss. Last stage, sphincter loss. You will be given the chronology. Which of the following stands true? as per the sequence of the patient of POTS paraplegia. 4 options: sensory, motor, sphincter, spasticity, motor, sensory, sphincter, something like that. So you'll choose spasticity followed by motor, followed by sensory, followed by sphincter. So that is something that you are supposed to remember. Indications for surgery for POTS spine. What was the first one? Symptoms are stationary or they are worsening. They have complicated into neurological issues. Neurological issues are worsening. Neurology is getting reoccurrence, compression over vital structures, and last but not the least, variety is not working at all, multi-drug resistance. So these were the indications for surgery. What was the name of the surgery? There is nothing which is important here called Hong Kong operation. You guys message me, sir, I've read there, I've heard there, I've listened to that. The Hong Kong operation is nothing. It is an anterior decompression of the cervical spine, particularly if you have to deal with the anterior tuberculosis or you have to deal with the cold abscess of the anterior triangle of the neck. The most common surgery which is performed is not Hong Kong surgery, it is ALD, and not only ALD, it is ALD with BG, anterolateral decompression with bone graft. Why? You're removing the diseased part of the body, yes or no? Yes. Don't you think you're supposed to fill it up? Or you just want to leave a gap inside the vertebral body of a spine of a person? So it is anterolateral decompression with bone grafting. What all structures do we remove? Posterior part of the rib, then associated transverse process, costotransversectomy, then part of the pedicle, then diseased body. Then you enter inside, you take out the disc. So what all structures are not removed per se? Spinous process. Another one, lamina. Are we able to understand this? So I just wanted to do a quick revision. So I hope you got the gist of the topic very well, and this is something that we see often in our OPD. Over to sir.
I think, yes, I totally agree with Dr. Tushar. I think we've covered one of the important topics, not only for your exam, also for your life. It is something which you will keep seeing, and even if you become an orthopedic surgeon, or you become a physician, you surgeon, or even if you become a radiologist, and sometimes even as a gynecologist, because you never know what kind of abscess could be because of a POTS spine. Because like Dr. Tushar already explained, and I also talked about it, that this abscess tends to travel long distance. Sometimes you see it in the anterior chest, and it's actually a POTS spine along the rib. It is abscess is going up. So it is like whatever specialty you go into, POTS spine is an important differential to be considered. And I think we have covered all the ground: how the patient presented, what are the investigation, the visuals, the surgery, and the outcome. I think in the new pattern of the exam, this is the 360 perspective that we talk about. That when we look at a system, we look at it with 360 perspective. And recently we have started integrated curriculum in the regular classes, and I can already see the feedbacks. You can see them on the Facebook groups. The students who are attending it, they are actually loving the sequence of our classes, the way cardiology is happening, followed by physiology and anatomy. We're putting things together. This integrated rounds is one of the initiatives where we try to look at a disease process or a MCQ in a joint manner. And I think, after this, at least you will not do a POTS spine MCQ wrong in the exam. It is a short question for next NEETPG, foreign medical graduate screening exam. Short question, POTS spine. One question you will definitely get because of the sheer commonness of the problem. Skeletal tuberculosis, out of the skeletal part, the vertebra or the spine is the most common part which is involved in TB, and that is why we need to know about it. And it has grave consequences on the patient. For you it might be just one disease, and for him it could be meaning his inability to walk, so you need to diagnose it early. You need to diagnose before the destruction happens, and that is where things like MRI and everything comes into play. Thank you, Dr. Tushar, for joining in, and thank you everybody in the chat box for joining in. If you have any comments or anything you want to let us know, do let us know on the Facebook group, and we are happy to hear you out and answer more queries on this topic further. I wish you all the best.
Thank you, sir. Thank you so much. Thank you, everyone.